Good morning. Thank you for joining us for this live webinar to help you prepare for upcoming changes associated with the implementation of Patient-Driven Groupings Model. My name is Stephanie People. I'm our Senior Director of Brand Marketing here at Axxess. So before we get started, let me tell you a little bit about Axxess. We are a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Today, you will hear from industry expert Tammy Ross, Senior Vice President of Professional Services here at Axxess. She leads a team of professionals that's goal is to provide practical operational solutions to home health, hospice, and home care agencies. Tammy has over 30 years of home health experience and has been a senior executive of a large national home health agency. Before we get started, I just have a couple of quick housekeeping items. So everyone's phones are muted. However, you are able to submit questions throughout the webinar. If time permits, our presenters will answer as many questions as possible at the end of the webinar today. And if we don't have time to answer all your questions, we will follow up with you following the webinar to make sure that we address every question that comes in. Also, at the end of the webinar, we will be sending out today a link to the slides, and then we will also be posting a recording of this webinar on our website, axxess.com/on-demand. All right, and with that, we'll go ahead and kick it off.
All right, thank you so much for that introduction, and thank you to all of you that joined us by phone and by computer. So good morning or good afternoon to you, depending on what area of the country you joined us at. Today we're going to be discussing PDGM success and staffing. We know these are the biggest challenges now facing home health industries, and I hope by the end of this webinar you'll have some practical applications to take away with you so that we're able to staff in this very new world of PDGM. So first of all, let's talk a little bit about the Silver Tsunami, growing healthcare demand. Our senior population, those being over 65, are going to double from 2018 to 2060. 1 in 5 Americans will be a senior by the year 2030, and 88.5 million people will be 65 by 2050. So as you can see, we have a huge need for healthcare staffing. As we look at some of the reasons people exit the market and exit healthcare, and particularly home healthcare, we look to Glassdoor and some various career builder sites, and these are direct quotes from, I love my patients, but after 6 months of staying up till 10 o'clock every night, I finally had to leave. Advice to management, relief of stress for the field staff, better training for employees. Documentation requires too much time. And we know with what's happening with PDGM in January, documentation demands are even going to be more stringent in the home health environment. Too many changes in home care. Well, that certainly fits with PDGM and what's going on in 2020. And as we start preparing for it now, just 2 months away, workload is equivalent to 2 full-time jobs. Paperwork is lengthy, the orientation is inadequate, and the training is poorly structured. So looking at Texas, which is where I'm coming to you from, in San Antonio, we took a look at a 2017 home health nurse exit and actually workload summary and statistics. And what we found from that actual study was the fact that nurses are basically given the same responses in this type of survey as they did online. There was 3 main reasons for nurses exiting. One of those was increased workload. The second was using administrative staff to cover multiple visits out in the field. And the third was personal reasons, fatigue, drive time, and work-life balance. We think we have the answer for those particular issues using AxxessCARE, and we'll talk about that a little later on. First of all, I just want to mention the turnover costs for you. Turnover costs for an RN ranges from $37,000 to $58,000. With PDGM and knowing that revenue is going to be reimbursed by Medicare and decreased in 2020, it's going to be very important that we try to control these turnover costs. As we go through this webinar, We're going to discuss kind of the basics of the new reimbursement system, PDGM. We're going to talk about technology enhancements to mitigate PDGM and some of those documentation challenges that comes along with that. And then we're going to look at AxxessCARE. We'll talk about AxxessCARE as it helps to grow your revenue, decrease your operational workload, and we'll also look at how AxxessCARE can actually improve your revenue cycle management, all very important with PDGM. So as we look at a PPS to PDGM comparison, you'll see on the left was our prior reimbursement or our current for the next couple of months, another 6 weeks anyways, we're under PPS. And then to the right of that, we're looking at PDGM. The thing that I want to point out with the differences in these two reimbursement models is the only thing that is directly influenced by the agency now is the functional status. Functional status will come still from OASIS data. Everything else under PDGM will actually be coming from claims data on the Medicare form. As we look at how does PDGM compare to PPS, we're just going to give you the basics. This isn't meant to be a full training session on the new reimbursement model, but just a few takeaways for you. Functional deficits contribute, but therapy count does not. In other words, there's zero incentive now for making increased therapy visits. There's no more 14, 19, and 20 therapy thresholds. Our HERV rate is going from 153 different payment categories to 432 payment categories, which is a significant increase in payment, making it much more complicated. Our LUPA threshold currently now in PPS is 5. We'll be moving to a 2 to 6 visit LUPA. Except for LUPAs and outliers, the volume of services provided plays no role in determining payment. So in other words, the more visits you do is not going to contribute to the amount of money you receive. And then we're going to continue to perform 60-day reassessments. That's not changed. However, we're going to have to do this within 2 billing periods. So let's look at how those numbers break down. And I like this graphic because I think it's a very easy way to break down the reimbursement. You have 12 clinical groupings that you see in the very first circle. 12 clinical groupings start the foundation for reimbursement. There's 2 timing options, early and late. There's 3 functional options, 2 admission source options, whether that patient comes from a community or whether they come from a hospital. And then there's 3 comorbid options or comorbidity options. And all of those multiplied together, if you take 12 times 2 times 3 times 2 times 3, that's how we come up with our amount of groupers being 432. As we proceed to the next slide, I will tell you that these slides have not been updated with a new final rule. Originally, the final rule was 8.1% in the proposed rule, and we know that we got a very good reprieve, and that reduction was reduced to only 4.32%. So the numbers are just a little off here, but not a whole lot or a significant amount to make a big difference. Our average payment for 30 days is going to be about $1,081 as we look at these clinical groups. And as you can see, our neuro group still pays a very high reimbursement rate, as well as our wounds. Both of those are high contributors under the PDGM model. As we go to our next slide, we're going to look at referral impact on payment. And we can see here that a huge impact on payment is seen with Lake Community. I apologize, guys. Those slides are jumping around on me. But as we look to Lake Community at 787 and move that into early institutional, which moves to 1,029. So those patients that are coming from the community that don't have a hospital stay are going to pay significantly less than patients coming from a hospital. Also looking at functional level impact. As we looked at functional level impact, we see that functional level is going to vary anywhere from 265 additionally for every 30 days to $457. And basically, this is the only thing that is impacted by the OASIS. This is where organizations actually have a chance to influence what they're being paid for Medicare. And as you look to our slides here, you can see that we have different payment dependent on the clinical grouping that they are assigned. But basically, if we just keep the 265 and 457 in mind, that'll give you the average. Looking at comorbidity scoring, comorbidities are secondary diagnosis scores. Those are the scores that come to us based on secondary diagnosis, like CHF, COPD, diabetes. Medicare understands that people that have more than one diagnosis are more acute, and therefore they're paying us more money to take care of those patients. We expect about 35% of our episodes to fall into a comorbid low category and about 10% to fall into a comorbid high. So not a whole lot of episodes are going to be affected by high comorbidity. And that's basically because comorbidity has to be paired in a certain manner to get this high reimbursement here of $333. So as we look to the impact model and we look to what some of the risks are under impact, we can see that questionable encounter codes, those codes that aren't specific, like mucosal weakness, gait instability, those codes are going to pay us less than many of our other codes are actually not going to pay us less. They're going to pay us nothing. They're going to get returned to the provider with a zero payment. And the provider is going to be asked to correct those. And if you can see here in kind of the peachy color here, this is a negative impact. And this is going to show us that this agency is going to lose all of those dollars unless they make that correction. The other area that we have that's going to be a risk or a potential problem area is those cases that end within 30 days. Those are your short-term hip, knees, IV cases. When they end within 30 days, you're only going to get paid half of the episode for those patients. So only half of your reimburser. And then again, we mentioned LUPAs in general. LUPAs are moving from a 5 visit threshold from 2 to 6. There's 432 combinations. And we expect most agencies to take a hit on this. Maybe not a financial hit, but we do expect the LUPA rates to go up. And then our last area is just overall, if we see all of our patients for 60 days, will we have an impact? Will our revenue go up or go down? Most agencies are going to experience about a 15% increase in revenue, providing they handle all of those other threats. So as we move to the next slide, what are the thoughts of the impact in PDGM? There's going to be a great chance for losses and for risk. There's going to be a great chance for agencies to maybe say, I don't want to take a certain kind of patient and actually limit access to care. We hope that doesn't happen. That's the reason we want to give you the tools. I'm fortunate to be sitting here with my parents that are senior citizens that may need home care one day. I'm sure you have family and loved ones that you want to make sure that this benefit's available to as well. So hopefully by using the tools that we'll give you within AxxessCARE, we'll give you tools to mitigate those risks so that you can still maintain financial viability under PDGM. We know that the impact to staff is going to be large under PDGM as the documentation demands increase. A lot of agencies are talking about increasing their productivity standards. All of these are things that could impact care to our elderly and frail, and obviously to our senior population in general. So let's talk about ways that we can actually decrease those risks. First of all, within Axxess, we have a questionable encounter alert. It's a pop-up. It's a warning that we have turned on as a warning now that will actually go to a hard stop January 1st. That hard stop being if you use a code that's not recognized under PDGM, and if it is a Medicare patient, the software will not let you proceed. So our staff that uses AxxessCARE will also have these pop-ups available to them no matter what device that they're using, even if that device is their cell phone. We also have a help center available with multiple training videos that'll teach the staff about questionable encounters, PDGM in general, and just where to locate and find all of the tips and tools they need to be successful under PDGM. As we go to our next slide, we talk about a PDGM modeling tool. I love this tool. It's available to all of the staff to use. And basically what this tool does is it enables all of the clinicians to actually choose, is that patient community early, community late, institutional early, or institutional late. Choose what clinical grouping that they will go into, and then the system will actually give them their case weight mix. It'll give them their LUPA threshold, and it will even show them how much potential revenue they're going to make on that case. And at the bottom, as I just kind of gave you a sneak preview to, there's actually a gross margin calculator so that we're able to put in how many visits we're planning to see if that's going to fall within the realms of PDGM to actually still make either a profit or break even. Now, we know all cases you will not make margins on. You're going to have some cases that you lose money on under Medicare and some cases that you make money on. But knowing this information in advance allows you to plan better your utilization of visits. So both of these are tools that are available within the software. Now, another thing that we like to talk about is OASIS real-time validation. When you use AxxessCARE and also Axxess in general, you not only get OASIS real-time validation, you get clinical real-time validation. It's kind of like having a nurse behind you as an instructor or home health professional telling you what questions to answer. It does the critical thinking for us. We like to call it artificial intelligence within the system. So basically, if you answer that this patient has CHF and COPD, and you use this as one of your diagnosis categories, and later on in your documentation, you document that that patient is not short of breath, the system's going to question you and ask you, are you sure this patient isn't short of breath? They have COPD and they have CHF, and your pulse oximeter is showing that this patient is only at 90% or 88%. So the system's going to pull in all of those data points and perform clinical documentation for you. At that point in time, when it finishes doing that, it's going to pop up either alert or hard stop, depending on if that needs to be a hard stop or just a clinical warning. So that's something that's built in the software and is available to all of AxxessCARE users. The other thing is mileage tracking. Being able to geo-map patients in a certain category or a certain area is very important as we look at saving costs in 2020 under PDGM. It's also very important to nursing staff because they want to spend more of their time at the bedside with the patient, not behind the steering wheel. So by using mileage tracking and geo-tracking, our staff is able to consolidate their time and do what they love to do, which is patient care, not windshield time. So as we go to our next slide, we're going to look a little bit at 30-day calendars. What we're doing in AxxessCARE and Axxess is actually putting a 30-day calendar in the system that's going to alert you if the potential schedule that you're going to do is going to create a LUPA. And LUPA being low utilization payment adjustments. We know that that difference in pay can be close to $1,100 for just missing one visit. So we wanted to put together a way that nurses could easily be alerted to their visits schedules. And that doesn't mean that we're going to maximize and give the patient visits that they don't need. But what it does mean, if your 30 days is ending towards the end of the month here, and you have the option of doing that visit either on a Thursday or a Friday, If you do that visit on Thursday, you're going to fall within the first 30-day payment episode and potentially not cause yourself a LUPA. But if you move that visit just one day, it's still within that treatment week, you may cost your organization up to $1,100. So being able to have this and have this available on a device in AxxessCARE is hugely beneficial to saving costs for an organization. Claims management considerations as we look under PDGM, we know now that claims are going to double. 2 sets of wraps, 2 sets of finals. If that's not bad enough, it's more than just pushing that button twice to send that claim to Medicare. It also requires us to do eligibility verification every 30 days. It requires us to manage all those return to provider claims, which are rejection. It requires us to coordinate benefits. It requires us to post and to adjust once a month instead of once every 60 days. So you can just think this through and think how vital it's going to be able to get your information back quickly so that you can do that wrap and do that final quickly. With AxxessCARE, these nurses are trained in the system. They're able to create that start of care very quick in the home, which means for you as an organization, you're able to drop that wrap very quickly. We are saying now average benchmark for wrap is 5 days. We have 5 days to complete an OASIS assessment. We should be able to wrap that claim within 5 days. And by using AxxessCARE, you're able to do that. So let's look at that nursing shortage again. We look at these numbers up front. 3.8 million registered nurses today, but only about 85% of those are practicing. And of that 85%, only another 85% practice full-time. So many nurses do not want to practice full-time nursing. 53% of registered nurses are 50 and above. That number is even higher when you are looking at home health and hospice numbers. We moved that needle up to about 55. It's about the average age of a home health and hospice nurse. And in 2020, we're expecting about 70,000 nurses to retire. And unfortunately, our nursing schools are not keeping up with the demand of nursing and the rate of retirement. So we have a limited pool of nurses, and out of that pool, many of those nurses are either not working or not working full time. So this is where AxxessCARE can make a huge difference to an organization's business practice. You can't grow if you don't have the staff that can help you grow. So by tapping into these nurses that are maybe not wanting to work full time, maybe not working at all, you're tapping into resources that haven't been used before. When we're looking at that turnover rate and we're looking at what we're doing in the industry now with nurses, we're burning them out. It costs us about $52,000 to replace them, and we're burning these nurses out very quickly because we're giving them high productivity, high acuity demands. We don't want to do that because for home care, it takes about 86 days or 3 months to recruit one RN, not to mention the cost associated with all of that recruitment. And again, the causes of that turnover, we have retirement, we have scheduling, we have staffing, and we just have fatigue and burnout. So average tenure of a nurse, once we get her on board in home health, it's only 19 months. So just a little over a year and a half, those nurses are exiting either home health entirely or they're exiting that certain agency. A lot of that reason is because of technology. Remember what I said, home health nurses are about age 55 and up. Technology has to make sense to them. It has to be easy for them to manipulate. It has to be easy for them to do their documentation, or they're just not going to stick with it. At Axxess, we have made sure that our team of product developers actually look at the age of the nurse, and they use me sometimes even as their guinea pig because I'm in that age group, and look at things to make sure it makes sense clinically and make sure certain things of where the options are placed and where the drop down is placed, that we're able to easily find that. What that does is it speeds up productivity, not just for nurses age 55 and above, but for all nurses and therapists. So let me introduce to you our product called AxxessCARE. AxxessCARE is Uberizing the way we do healthcare. It's connecting professionals to agencies and ultimately to patients. So we like to look at this triangle because all three of these are connected using AxxessCARE. We even give star ratings of AxxessCARE both by the clinician and the agency. So let's take a little bit deeper dive into AxxessCARE. So first of all, the very first thing I've been talking about is that productivity. There's a couple of wins with productivity. Nurses, therapists, they want to perform patient care. They don't want to spend all their time documenting. So if we can improve the efficiencies within the system, we're improving nursing and therapist satisfaction rates. The other thing by improving productivity is we're improving margins of our agencies. If we can increase productivity from 5 visits a day to 6 visits a day, because that documentation is much more streamlined, we're improving that gross margin for that agency and that viability of that agency up to 20%, depending on how many additional visits that we're able to improve by. I've even seen agencies improve over 50% in their productivity when they're using this particular product, because it's not just the productivity of the field staff, it's the productivity of the back office staff with scheduling. And we'll talk a little bit about that later on, how streamlined the scheduling process is. The big win with AxxessCARE is LUPA avoidance. We are able to avoid those LUPAs that may happen if we don't have the staff to make a quick visit. Maybe that's a patient that's coming home from the hospital unexpectedly, and we need to do a resumption of care the next day. They came home at 9 o'clock at night on a Thursday. We need to see that patient on Friday. However, there is just no staff to do it. Patient is stable, and we want to push that visit to Saturday. Well, if that's at the end of that 30-day payment period, we might have just caused a LUPA for our organization and cost our organization $1,100. So being able to access this additional staff quite quickly. Rehab management, we know this is going to be huge with with PDGM in 2020. We know the number of rehab visits are most likely going down, but yet we still need to be able to find good therapists when we have rehab cases coming into us from hospitals. We can supplement our rehab team using AxxessCARE and be able to take more of those rehab cases, which again pays you at a higher reimburser. It's a higher clinical grouper. Program development. If you'll think back to those original slides, wound care is a very highly paid clinical grouping. Many organizations are thinking about starting wound management programs again, but they don't have the resources to invest in a full-time wound care nurse. You can actually request WOCN certified nurses, ostomy certified nurses through AxxessCARE. And those nurses have been competency evaluated, and those credentials have been uploaded onto the system. Same way with IV therapy, again, highly reimbursed under PDGM. And maybe you haven't had an IV therapy program. Maybe you want to see how this program's going to work. So this particular technology solution called AxxessCARE can connect you to IV certified nurses. And again, we talked about the decreased cost to mitigate potential revenue reduction. Think about that geo mapping. Think about not paying exorbitant mileage fees. Think about satisfaction levels, keeping those clinicians in a geo-tracked area. We can also grow additional revenue streams using specialty programs. So maybe you want to start growing a dementia program or a behavioral health program. Again, using AxxessCARE to connect you to clinicians that are certified or competency evaluated in those particular areas is a way that you can grow those programs. OASIS functional scoring built into Axxess and AxxessCARE, actually a scoring system. It's the OASIS guidance manual that basically tells nurses how to score OASIS, not actually tells them how to score it, but gives them hints for scoring. And remember that artificial intelligence that's built in for clinical reliability, that's all available to them on any device they use, including their cell phone. I mention that quite often, and I know some of you nurses are out there thinking, oh my goodness, I wouldn't want to do it on my cell phone, it's too small. I can tell you that many of the AxxessCARE nurses love to do their admissions on their cell phone because they're used to that system. They're used to their phone, they're used to the way it operates. It's very easy and comfortable for them to use. And the way that we've actually lined it out on a mobile device makes it quite easy to do a full start of care on a cell phone. The other thing I mentioned is days to wraps and finals. We know that we can improve this quite quickly using AxxessCARE. These nurses are paid when their documentation is completed. So, and therapists, well, I can tell you, they want to get paid quickly. So they make sure their documentation is completed timely. They make sure it's completed in the home because, again, it's very easy to do using a mobile device. So your days to wrap and final will be actually quicker than using any other system when you use AxxessCARE. So looking at increased productivity, I just took this out of Home Healthline May 6th. About a third of the agencies that was polled by Home Healthline wanted a way to improve productivity. They also wanted a way, they said that they were going to increase productivity of their nursing staff. So what better way to do that than to use technology to help you do that? Your staff can make those additional visits. They can increase that productivity if those operations are streamlined. Some things I would tell you to think about is maybe giving incentive bonuses if people make productivity plus. In other words, they're at 110% productivity, but they still have the ability to pick up a couple of extra visits. You might want to pay them a per visit rate for being able to do that for you. And again, integrations is huge with productivity. Being able to integrate that patient information quickly and seamlessly, and only having to document things one place. And with AxxessCARE, all of our technology is built on one source documentation. So LUPA threshold, we talked about this. I told you about $1,100 was the cost of a LUPA. We're actually using the 2019 LUPA rates to actually come up with our numbers. But if you look on the left, you see the actual LUPA threshold, the number of HERGs that are affected by that. So 2 visits, there's 94 HERGs affected by the 2-visit LUPA threshold, or 22%. And you can see 4-visit LUPAs is the highest area, which is 137 or 32%. And then if you look at your graph to the right of the screen, you can actually see that math that I talked about, how a visit can actually cost you about $1,100 for missing one visit. Maybe because you didn't have the staff to be able to do it, or maybe because you wasn't using a 30-day calendar and you placed your visit just one day late after the 30-day billing period. So I think this is significant. Even if you have to pay someone to do a visit or start a care a little bit more than you would normally pay them, that cost is a lot less than this $1,100 that you stand to lose if you actually do a LUPA visit or hit a LUPA threshold. And this is just explaining that a little bit better. I'm just going to quickly walk you through this. This is a case where we're on a 30-day calendar. Our LUPA threshold is 6 visits. We have a 30-day billing period. Our start of care started on a Thursday, And our end of billing is right here on a Friday. I call that an EOB, or end of billing. When I scheduled this patient originally, I had scheduled to prevent that LUPA. And if you'll look here, I had 1, 2, 3, 4, 5, 6, 7, 8, 9 visits scheduled. So I was well out of that LUPA range. This would have been a full visit episode payment. But what happened is, instead of getting in all those visits, the patient went to the hospital. And you can see we did everything right. We front-loaded our visit. The patient still went to the hospital on a Monday and remained in the hospital for, a little over 2.5 weeks. They came home from the hospital on Thursday. Now, I should get out there and do my visit on Friday, but I have my director of nursing out in the field doing admissions. I have every nurse scheduled at 6 visits, and even my LVNs at 7 and 8. I have no way to get out here and see this patient on Friday. So I'm going to move that visit to Saturday and let my weekend nurse actually do that visit. By moving that visit to Saturday, I just caused a LUPA because I only did 5 visits instead of 6. So that cost $1,100. What I could have done is, when I saw that here on Friday, I didn't have the staff available, I could have externally posted this visit to AxxessCARE, and nurses, and they would have to be RNs because this is a resumption of care visit, nurses would have applied for that visit. I would have offered a certain rate to go out and do that resumption of care. I might even have put $100 on that ROC visit, because that's how important it is I get out and see that patient. And I would have had multiple nurses applying for that. Generally, within the first 2 to 4 hours, you already have applicants for your particular visit. And at that point, I could select the applicant that I best liked, maybe one I had a relationship with, and I could have scheduled that visit and prevented that LUPA. That's the actual power of AxxessCARE. And here is actually this in action. You can see our nurses here. These are all nurses that could have applied for the visit. I can even see their star rating. You can see the one we have highlighted here has a star rating of 5. That's very easy to see. And that star rating is based on both patient satisfaction and patient visits, and it's also based on agencies. So out of all the agencies and all the patients that this particular nurse has went to, she has 5-star rating. And she's also an RN, and she also lives in that geographic area that is close to the patient. So it kind of is a no-brainer. I'm going to select her to actually perform that visit. So functional scoring, we talked about that. We talked about functional scoring of bringing in almost $432 extra based on going from low to high. So if we score that patient incorrectly, we stand to lose a lot of money. Using AxxessCARE, our nurses, again, had that artificial clinical intelligence built in that helps them score OASIS. In addition, we have the fact that we have the OASIS guidance manual built in. These nurses are used to doing start of cares, resumption of cares, so it's not like you're taking a nurse that's never done an OASIS before. You have nurses that are highly trained. And if it's very important for me to be able to get a very good OASIS trained nurse, I'm going to look down in some of my comments and see what other agencies are saying about them, how they score functional. And I'm going to pick that nurse that really has the highest scores on OASIS and making sure that they get the correct information on OASIS. So very important, again, up to $432. Therapy and AxxessCARE. So we're not just for nurses, for therapists as well. We know there's no additional payment, but we know we still have to have those outcomes in PDGM. So we can use AxxessCARE to supplement PTs, PTAs, OTs, and CODAs, speech therapists as well, because we may have a reduction of our full-time staff in 2020. We may not have as many full-time staff on board, but there's going to be times that we need to supplement process. The good thing is therapists are very accustomed to using this type of model. They've performed contract therapy in the past. They've worked for multiple organizations in the past. They're usually very good about getting in their paperwork timely. Again, this is something that's very comfortable for them. It's been going on in the industry, 15 or 20 years. So our therapists are going to be very used to this. In addition, we're going to be able to see their star ratings. We're going to be able to see if they're OT, PT, or PTA, because again, if we need to do a functional 30-day functional reassessment, we're only going to want those PTs. And the good thing is we can set that when we set up our posting, we can say whether or not we want a PT or a PTA, so that only those people that are actually qualified for that visit will actually see those visits. You never have to worry about a mismatch. You never have to worry about this PTA applying for a visit that is only to be performed by a physical therapist. So we take care of that for you within AxxessCARE. We can also target skill sets. Maybe you need a therapist that can do maintenance therapy, and you want to target that particular skill set. Or you want an ST that can do cognition exercises with your dementia patient. You can target that and put that on your external posting. So program development, again, we talked about this a little earlier, but here's some program development that we have seen already in AxxessCARE, and we have seen organizations actually double their business. There's an organization in Dallas that has grown their census double within about 3 months period. They attended a similar webinar we did on AxxessCARE probably at the beginning of the year. We wasn't really talking about PDGM, but we were talking about the value of AxxessCARE. They got on board with it. They were excited about program development. They grew their census, actually doubled it in about 3 months. Some areas, I'm not sure they used all of these, but some areas that for you to consider is IV therapy, wound therapy, rehab nursing. Maybe it's time to start focusing on those outcomes using nurses rather than rehab staff. So rehab nursing is a good way to still meet those outcomes. Management and evaluation of care plan. This is a skill that is done always by an RN, usually a bachelor's or higher prepared RN, and it surrounds chronic care management. These are patients that would basically end up in the hospital if we wasn't there to manage that non-skilled care. There are nurses that absolutely love this skill. It usually requires no direct care, no lab draws, no wound care. It requires coordination of services. This is a great skill maybe for those nurses that don't want to work full-time, or these older nurses that maybe don't have as good of direct skill set as they once had. Management and evaluation is a skill set that they can get behind. And it's also a way to manage your chronic care population efficiently and still make gross margins under that. And then maintenance therapy, we talked about that, running a therapy maintenance program, which is still payable under PDGM. It's still reimbursed under PDGM. And I think as we start moving and we start looking at ways that we can save cost on therapy, but yet still meet those really good outcomes, maintenance therapy is going to play a big part of that. So management evaluation concepts, I do want to just mention this is not something that you could just go out and start tomorrow. There are certain skill sets required for that. Physicians have to document that there's a need for management and evaluation. So I would encourage any of you that are looking to do management and evaluation, really do your research on that first so that you can start that program. Maybe even make that part of your coffee for next year to look at a management and evaluation of care program. And this is just an example of those margins I was talking about under M&E. This particular program also avoids LUPAs because we use a lot of home health aides. And if you'll look here to my calendar on the right of the screen, you can see that I'm using home health aides twice a week. I'm using telemedicine. I have a telemonitoring machine that I actually aggregate all of that data into my charts every Friday. And then I also make a telephone call. Now, a telephone call is not reimbursable under Medicare, but I make a telephone call to that patient, making sure that we review all of that telemonitoring information. Maybe you don't have telemonitoring equipment. That's okay. You can still just do it by the telecall, by just making the phone call. You can see here that looking at the number of visits that I've made 8 home health aid visits that comes to $530. 2 nursing visits every other week, but I called them the weeks that I did not see them. Your home health aid visits count towards your LUPA as well as your nurse visits. So 2 RN visits at $293. If I add those 2 up and I subtract it from my $1,400 that I received from this late community, low comorbidity, mid-functional cardiac patient, I will have made $647 off of this patient for 30 days. That's actually the profit margin. So you can see how this could be financially a very valuable program to run using management and evaluation. And AxxessCARE can help connect you with those nurses that are skilled in doing this. We just look at the cost savings. These nurses are generally 1099 nurses, and I'm going to use the nursing example. And if we look at a nurse salary at about $78,000, we can see that the cost savings and benefits is about 31.7%. That's $25,000 of cost savings by using 1099 employees rather than full-time employees. And that breakdown is Social Security is 6.2%, Medicare is 1.45%, paid time off is 9.65%, insurance is 9%, and retirement savings is 5.4%. So remember what we looked at before. I love my patients, but after 6 months of staying up till 10 p.m. every night, I finally had to leave. That doesn't happen in AxxessCARE. If you use AxxessCARE, you can balance that work-life balance for your staff and make sure that they don't turn over in just 18 to 19 months' time. And when we look finally at a couple of KPIs, these are actual true KPIs from an organization we helped out not long ago. They were losing about, I want to say that's about 95%, this big blue arrow here. This is no availability of staff. This is the reason they intucked or did not admit or couldn't accept patients. So about 95% of that was because no staff was available. The other reasons was patient refused care and other. And when we drilled down other, it was because it was too far out of a geographic area and the nurses didn't want to drive back. So by using AxxessCARE, they turned this around, and all of this business that was going out the door turned into viable business for them that they could actually admit. I want to say their non-admission rate now is down to about 5%, and it was almost 60% prior to AxxessCARE. And the value of AxxessCARE, we're going to increase your revenue. We're reducing your overhead by reducing your staffing costs, your LUPAs, and your FTE costs. We're streamlining that operation so you can post internally and externally. We're ensuring compliance by making sure that all the competency evals are done. AxxessCARE does the licensure check. AxxessCARE also does the OIG check. All of that is uploaded and included with all of those staffers' comments. We are able to improve patient outcomes for you just by making sure we have that timely care and quality clinicians. And finally, is that employee satisfaction. Your employees are satisfied because they're not going to experience the burnout that they experience when they're having to do 150% productivity. So in summary, PDGM is creating both organizational threats, but multiple opportunities for organizations. Now's the time to rethink about your strategic plan. Think out of the box. Think Uberization with AxxessCARE. Think about quality studies for management and evaluation and maintenance therapy programs. Let technology assist you with these management programs, and let AxxessCARE mitigate those major threats under PDGM and control those for you. So I thank you for your time today. I would encourage you, if you have questions, you can send those in. We will do an FAQ and mail those out to you after the seminar, probably about a week or so after the seminar. If you'll send your questions in, we'll be able to get you those answers back to you. And we'll send all of those questions out to all of you. I would encourage you to schedule a demo if you need to on AxxessCARE if you're not already familiar with it. You can certainly do that. We have a large team there that would be happy to show you that, or go online and take a look at it. Okay, so I just want to thank you for your time today. And again, if you have questions, make sure you send those in. We'll take all those questions, we'll put those together. And in about a week, from 10 days, we'll send that out to all of our attendees. The other thing we'll do for you is we are recording this. So we'll make that available to you, a video recording, as well as the slide deck. So you'll be getting all that information from Axxess. So look for that to come in your email, and look for that to be posted as well. So thank you for your time today. I look forward to talking to you in the near future.